And I'll turn it over to Jennifer. You're on mute there, Jennifer. If you did.
Sorry, Jay. For some reason, I always have such a hard time getting it out of the header like that. All right. So thank you, Jay, for that lovely introduction. So my name's Dr. Jennifer Prss. I'm a psychologist with Marshall's Jones C. Edwards School of Medicine in the Department of Family and Community Health. I also do a lot of work specifically within our Division of Addiction Sciences. Part of the faculty that developed this PPD ECHO, and I also work with a lot of moms who are in recovery from substance use disorder. So I think throughout this series so far, you've heard about the importance of medication as part of a treatment plan. Laura Lander shared last session about psychotherapies and different models of therapies that can be used with this patient population. And I want to talk about the kind of and the other. So the things that are not technically medication, not technically psychotherapy, but are of great benefit to our patient population for a lot of the reasons that have come up in our previous discussions. So a lot of our patients face a great deal of stigma, both in the kind of in healthcare in general, but also self-stigma by virtue of being a parent with a substance use disorder. There are also numerous psychosocial barriers that can come up for our patients, such as economic problems, legal issues, employment issues, relationship issues. And so we want to talk about today, what are some of the supports that we can put in place so that our moms and their babies can really benefit from the types of treatment that we've already shared. So what I hope to accomplish today is to talk about different components of recovery support. We're going to cover at least 3 evidence-based components of recovery support. Recovery support access. So we'll talk about different ways that you can help mothers with substance use disorder to access recovery support, and also to provide an example of the system that we have in place in our healthcare system, which we refer to as Healthy Connections. I know that from recognizing names on our participant list, we have a lot of folks that are part of DFMB programs in your own community. So not every system is going to look exactly the same. And I'd really love to have some discussion about how we can take these principles and implement them a little bit differently depending on where we are. So I'm starting with a quote that I had from one of my patients who recently shared this with us last week, that I wasn't going to go unless I knew I could do it this time. So a lot of our patients have had experience, some good experiences, some bad experiences with substance use disorder treatment. For a lot of the moms that I've worked with, they weren't necessarily interested in treatment when they discovered that they were pregnant, and then that really tipped things in favor of seeking treatment. But a lot have had an experience similar to this patient where in the past they felt they couldn't do it for whatever reason. So what we want to do is to provide them with the supports that patients are going to need in order to be successful. Some of the components from SAMHSA guidelines. I don't expect you guys to squint and read that. This is from one of the fact sheets in the SAMHSA guidelines for treating pregnant and parenting women with opioid use disorder and their infants. So I'll read quickly. Many people find that for lasting recovery, they need to control stress, avoid places and situations where they once used drugs, and even end relationships with people involved in drugs. When making these changes, people in recovery may find that peers, such as other mothers in recovery who experienced a pregnancy affected by opioid use disorder, can help them in a way that healthcare professionals cannot. Limited but promising research supports the role of peers who are in recovery from an SUD. Personal safety and adequate food and housing are also essential to both short and long-term recovery. We spend a lot of time in the healthcare field talking about the nuances of our little individual components of the field, whether that be medication, the best methods of psychotherapy. And really, if our patients don't have a safe place to rest their head at night, they're not going to be able to participate fully and benefit from those services. All right. Ooh. Click back. All right. So I know with Maslow's hierarchy, there's some ableist implications with it. But the reason I'm showing this now is I want you to think about with your patients, in order for them to actually be able to learn new information, start new habits, learn skills needed for self-regulating of their own emotions. Those are really a little bit higher up on the hierarchy. Those are things that really can be accomplished when physiological needs, a sense of safety and security, and having some form of relational connection with others. Those ingredients have to be met before we can really see folks be able to relax and engage the parts of their brain that they're going to need for this really deep work. So folks from DFMB sites are going to recognize this service right away because this is part of the maternal opioid model, the MOM project that we're working on with CMS and the state of West Virginia. And these are services that the Medicaid and managed care organizations are starting on a pilot basis to cover for moms with a history of opioid misuse during pregnancy and within 1 year of delivery. So the first thing is a needs assessment and care plan. I kind of put those two together because they're kind of two sides of the same coin. So having a dedicated staff member who is able to do an intensive needs assessment with each patient and come up with an individualized plan of care to know how to best help this patient. So what does this usually look like? So it includes SBIRT, screening, brief intervention, and referral treatment, taking a thorough client history, identifying the mother-baby dyads needs, both practical, in terms of housing, food, diapers, formula, but also socio-emotional. Is mom in need of a social support network, friend group, a sponsor, things of that nature. To gather collateral information, for example, reports from staff on mother-baby unit. A needs assessment and treatment planning process really should involve active participation from the mother and from all members of the treatment team. It shouldn't be kind of boilerplate that we just have moms sign. They should really be active in helping us understand what is their highest priority and why. The care plan specifies the client's goals and actions to meet needs and identifies the range of services, the nature of services, frequency of services that the client's going to receive. And this is to be reassessed periodically, both in terms of chronological time, every 90 days or so, but also if there are important treatment junctures, such as planning for delivery and what services might look like after delivery versus before delivery. Who can do this type of service? In our healthcare system, because we are implementing the MOM model, that role is fulfilled by a care coordinator. The title that we use in our healthcare system is family navigator, but that's the function as a care coordinator. Also, another possibility might be a case manager. If this is occurring, for example, at a comprehensive substance use disorder treatment program. A case manager can do these functions. Typically, social work and nursing will perform some, but not all of these functions. Not every patient may get an individualized care plan, for example, but in general, all programs require some form of history to be taken from the client. But anyway, this just creates the roadmap of the support services that we want to offer. Care coordination in a little bit more detail is, I always find myself referring to it in our healthcare system as freelance case management. So I've been a case manager before, and in that role, you're really sometimes tied to your agency and either what resources are available in your agency or potentially losing that relationship if the client moves on from your agency for whatever reason. But within our healthcare system, we really expect our family navigators to follow moms from pregnancy to the postpartum period to those kind of early years where they're finding their footing as a young family. They can follow them wherever that they may go. So the care coordination services are going to look really similar to case management in that respect. So what can you do? Under care coordination, identifying community resources and maintaining those relationships. A lot of what we do is, when in the process of making and accepting referrals, is making sure that we have good functioning relationships with other community organizations. We make sure that if there's something new that we didn't know about before, that we contact that person and try to find out what's the criteria for your program, if it's something that's going to benefit our clients. We also try to chat about what are gaps we see in the community and maybe informally brainstorm some ways of taking care of those. And that's all behind the scenes of our actual hands-on work with the clients. Linkage and referral to community resources, facilitating access. For example, part of one event with a client might involve putting them in the family navigator's vehicle and driving them to an appointment that they have helped to set up for the client. Advocacy, for example, with Child Protective Services or with other entities. I think one of the most powerful times I've seen advocacy work was with a client who was eligible for subsidized housing and had called, I won't name the agency, but over and over and over and over again, when we really saw her struggle, family navigator called and identified themselves as a social worker, and we really had a response within the same day. So sometimes those little things you don't realize that you're providing for clients is extremely powerful. Because had she lost her housing, that really would have could have destabilized her very quickly. Handling crises as they come up, managing transitions of care, which we're going to have a kind of a separate talk on at the end of the series. And handling paperwork, for example, making sure that we have appropriate releases of information for everyone so that we can all communicate about the client. Who does this? The care coordinator. And again, typically there's some availability of staff to do some of these functions, but really having dedicated staff that are able to meet these needs for clients is extremely important. All right. Health education and promotion. This covers a lot of different things that you may not even realize you're already providing to clients. So this may be providing educational materials and referrals for non-emergency things. For example, we will refer patients to lactation consultant and discuss what are some of the benefits of breastfeeding for both mom and baby. Breastfeeding education, contraception education, nutrition, parenting education, and information about child development. Who does these things? Again, care coordinator is able to do that if you have one in your program, but also nursing and specialty consultants such as a lactation consultant. We partner with WIC. We've had WIC come to our group therapy and talk about what services are available and the importance of that extra nutrition during pregnancy. And also a doula is someone that can provide this type of service if you are fortunate enough to have doulas accessible in your area. home visitation services. So you may not think about home visitation as recovery support, but when you're talking about moms with substance use disorder, it is a vital part of making sure that our families have that kind of wraparound support after they leave the office. Voluntary home visitation programs, or I should say participating voluntary home visitation programs, is one of the most powerful things we can do as a community, or encouraging that participation is one of the most powerful things we can do as a community to prevent child abuse and neglect, and to prevent decompensation of parents when they are raising very young children. So some of our partners that we have as part of the Healthy Connections Coalition, and this is going to vary depending on your region, but we partner with Right From the Start, which is a program through West Virginia Medicaid that will provide some care coordination and also in-home services such as visitation for individuals who are pregnant until the baby is 1 year old, and that is for Medicaid enrollees. Mountain State Healthy Families, which offers home visitation for individuals who are pregnant through 2 years of age. There's no income guidelines, and this one is not tied to any specific payer or insurance. So some folks may not realize that they could qualify for Mountain State Healthy Families. So if they don't have West Virginia Medicaid, if they have private insurance, they could still qualify for a similar program through Mountain State Healthy Families, where they're receiving visitation, home visits, some coaching, parent coaching, and education. Birth to three is a little bit different because it does require some qualifications to participate. So this provides assessment and intervention for children who have potential developmental delays. Again, I think more people qualify for this service than are aware that they qualify because they accept kids that are already determined to have a delay. But if a child is at risk of a delay, the staff from Birth to Three can actually do their own developmental evaluation to determine whether there are needs that can be met by their service. I like to give the example that I have a very close friend whose child you would have never really been able to know had a delay because she didn't have a full delay in any one domain. She had a partial delay in 2 different domains. And that actually allowed Birth to Three to work with their family from the time she came home from the hospital, essentially, until she was ready for preschool and was able to start receiving services through Head Start. So some of our families may have the misconception that their child has to have a very obvious disability to qualify for Birth to Three, and that's not the case at all. Head Start access is going to be a little bit different depending on your region, but it is a federally funded program, so you should have access, or your family should have access to Head Start. Early Head Start is available for children ages 0 to 3, so prior to the classroom-based Head Start. Early Head Start's available, and it does have a home visitation component to it. You can also help families whose children are at risk to help them prepare for kind of working with the public school system, potentially, developing an IEP in the future if those things are needed. Head Start is predominantly income-based. However, depending on, if your particular Head Start program in your area, if they have a certain census level where they're able to take additional, sometimes they will take disabled children who are qualified with a disability, even if their parents exceed the income guidelines. So that's always an option. Okay, one of my favorites, peer recovery support services. So what is it? In West Virginia, PRSS services are defined as doing one of these functions that are listed: teaching self-help, system advocacy, individual advocacy, recovery planning, crisis support, relapse prevention, housing and daily living skill development, and can also help with educational and employment planning. The difference between PRSS services and care coordination is the type of experience that the professional has. So in the case of a PRSS, this is a person who has lived experience with substance use disorder, who's in recovery. For West Virginia credentialing, they have to provide a statement of their recovery. Certification requires 46 hours of education, 500 hours of on-the-job experience that can be paid experience, and ongoing continuing education and supervision are required. Let me see if I can move this little hickey out of the way. Yeah, ongoing CE and supervision are required. Also, I should note in West Virginia, as of this October, well, West Virginia will require to be able to bill for PRSS services. The coach has to be certified through our licensing, WVCTSI licensing for addiction professionals in the state. So I think in some ways that's a good thing to have some kind of quality control. But as you can imagine, for areas that don't have a ton of resources, that could be pretty challenging, making sure that everybody is certified by October 1st. So it'll be interesting to see how that plays out in real life. All right. And I want to pause here for a second to emphasize the difference between PRSS services and what we as professionals maybe think of as peer services, peer recovery, and how I would refer more accurately as mutual support. So a PRSS is a professional. This is a paid position, and it's someone that requires substantial training and to pass a written exam. Mutual support is really a structured form of, I would say, voluntary helping. So it's different from PRSS services. Some types of mutual support that I think, I've seen be of benefit to patients are 12-step, which most people are familiar with AA and NA, Alcoholics Anonymous and Narcotics Anonymous, but there are several, similar programs that are just have a slightly different focus. I know there's a Cocaine Anonymous, Adult Children of Alcoholics and Dysfunctional Families, Al-Anon for folks who are still living with someone who or have in a close relationship with someone who's active in their substance use disorder. So whatever your challenge, you will probably find a 12-step group that is up to meeting that challenge. 12-step groups, I do want to clarify, these are spiritual recovery programs. Although many people find participating in 12-step therapeutic, it is not the same thing as therapy. And I think sometimes, maybe not so much for folks on this call, but I've found in the community, sometimes there's a confusion about how much you can require people to participate in something that is essentially a spiritual connection with other sufferers of your same condition. As 12-step programs, and I don't want to overgeneralize, but those that follow AA's model are not affiliated with a particular religion. Different meetings vary in how much of a particular religious tradition they involve in the meeting. So for example, in some AA meetings, people may pray together, use God when they're referring to their higher power, and others may be openly agnostic or atheist. Just depends. You just read the description of the meeting before you attend. Smart Recovery, which has a similar format to 12-step. However, it has a science-based curriculum and is led by trained volunteers. In 12-step, your service or your giving back is part of your own recovery. And so people, attend meetings, they learn the rules of the meetings, and then are able to lead a meeting as part of their service. Smart Recovery actually requires facilitators to be trained in that specific model, and it's largely CBT is what I would say. For those who are not familiar with Smart Recovery, a lot of the modules are similar to cognitive behavioral therapy. Celebrate Recovery, which is, again, similar to 12-step programs. They use the same 12 steps that are developed by Alcoholics Anonymous, but it is an explicitly Christian application of AA's 12 steps. And for the most part, all of the Celebrate Recovery meetings that I've been familiar with, kind of across, how do I say this? Whatever you're recovering from, you can kind of all attend the same meeting. So as opposed to more traditional AA and NA, where most groups are segmented out by topic. So if you're have an eating disorder, you're Overeaters Anonymous. If you have an alcohol use disorder, you go to AA. And Celebrate Recovery in general, these are held in churches, and whatever you're recovering from, everyone attends the same services. I recall from kind of first doing substance use disorder evaluations for people involved in child welfare cases. People would say they were in AA and be in Celebrate Recovery and vice versa. Like, I think sometimes there's some confusion, but Celebrate Recovery is explicitly Christian based on the 12 steps. Recovery circles is kind of newer in my experience anyway. We have recently in Huntington, Recovery Point has opened a recovery cafe using the recovery cafe model. And it is, if I were to use kind of vocabulary based on like my clinical experience, they remind me of drop-in centers, but they're run a little bit differently. So it's meant to be a really supportive environment, and the milieu is extremely important at creating that support. So there's like coffee and snacks available. There's always groups of people ready to chat. There's, again, paid and credentialed PRSS staff on hand to be able to do crisis intervention and things of that nature. And our local to me, Huntington's local recovery cafe also has some barista classes. So it's just meant to be a positive experience where people can go in their downtime, which, as you know, for people, particularly people early in recovery, downtime can be a dangerous time. So it's to provide that supportive environment. And the recovery circles are their mutual support meeting that's held within the context of the recovery cafe model. And my understanding is that they're a little bit more open-ended. They're not as structured as meetings in Celebrate Recovery or 12-step or Smart Recovery, which is also very structured meetings. All right. So how do we help our patients get all of this good stuff? So at the top of my list, DFMB programs. So if you are not already connected to a local DFMB program, find out who is in your area and how, what's their referral process so that you can connect patients to that extra level of support. If you are in an area where you don't have a DFMB program, and I'll flash a slide here in a second to give you a visual, but that does happen in West Virginia. You can check your patient's MCO, their managed care organization, especially for West Virginia Medicaid. They have a lot of value-added benefits programs, including, and I know Aetna Better Health, and I believe Unicare, and I know I saw someone on the participant list. So I apologize in advance if I'm leaving out your MCO, but they have care coordination and education programs specifically for mothers with substance use disorder through their neonatal abstinence syndrome programs. So that's another spot to check out if you don't have someone local to help you. Home visitation programs. So, some of our home visitation programs in West Virginia are understaffed, so it can be difficult from a practical sense to access. However, we are very lucky as a state that these are provided for every family, essentially, in West Virginia can participate in a home visitation program during pregnancy and those very early years. That's not the case for all states. Another option to think about is creating a referral partnership. Depending on who you are, because we are an interdisciplinary ECHO here. If you are providing MAT and you would like to connect with someone that already has a PRSS on staff, looking into behavioral health or SUD programs and kind of really cultivating that referral partnership with them. And one that you might not have thought about, but something that we see who are really successful. Sorry, folks, I'm getting
You froze up there for a second, Jennifer. Yes.
I was going to say I got a warning that my internet connection's unstable, so I apologize. But just so in the rooms in fellowship, often we will say, you look for who has what you want and ask them how they got it. And so sometimes we'll do that with patients also. So for our patients that are doing extremely well, we ask them, well, where do you go to meetings? Where do you find your support? And try to we get like a vetted list of places where our patients who are pregnant maybe would feel more comfortable. Okay, so here's a slide on the West Virginia Perinatal Partnership website. This is interactive on their website. This is just a screenshot on my presentation here. But each of the circles and the little shields are treatment programs, and the like little red hearts that you can see are, I believe there's another one that represents the DFMB symbols. I'm teaching from a tablet today, folks, so I apologize for not being able to see these so well. Play around with it on the Perinatal Partnership website. It's really cool. You can zoom in, and you may have more in your region than you're aware of. But again, if you'll kind of just eyeball our state, we have a lot of areas where there's not a lot of resources. So try to kind of form partnerships with folks that are reasonably close. A lot of places that are behavioral health and SUD treatment providers, even if you're just looking to maybe add either that therapy component or that PRSS component, a lot of folks are doing it through telehealth these days. So you may be able to form a referral relationship where you can get your patients access to those services, even if there's not something physically located close to you. So why do patients need our help, right? Well, aside from all of the various stressors that we've talked about over the last several months, here are some things that I've heard from patients about why is it hard for them to find their own support. So some barriers that I've heard are being afraid to be seen in a meeting while pregnant, not having a ride to a meeting or not having a meeting at all in the town where they live, not having childcare during the meeting. And we hear these things quite a bit. So what are some things that have worked? As I mentioned, maintaining a list of in our case, it's usually MAT friendly. So meetings that are not explicitly anti-Suboxone or Subutex. We try to keep a list of those meetings that past patients who've been successful have attended. You can also encourage attendance through online platforms such as intherooms.com. In the Rooms is pretty cool as a provider because you can get a completion certificate. So if you track attendance in meetings as part of your outcome measures or your compliance measures, it's a really useful platform. There are numerous free apps where clients can reach out, including several that are specifically being piloted in West Virginia right now, such as the Chess app. And also there are more prescription digital therapeutics that are coming on the market that are specifically for MAT providers that don't necessarily have therapy in-house. And they can prescribe these apps that are paid apps, but they are can kind of help to supplement traditional therapy, essentially. Other things to think about if you work with a lot of moms who are pregnant or postpartum is to allow moms to bring their babies to group or to provide childcare at your facility. Okay, so I'm going to talk a little bit about healthy connections, but I want to make sure we have time for discussion also. So what do we do? This is both our community coalition, where we meet monthly to discuss kind of developments in areas of relevance to pregnant and parenting families with substance use disorder, but it's also what we call our DFMB program. We help pregnant women, mothers, and their families to navigate treatment and support services available in the community. Family navigators provide the foundation by serving as that care coordinator, but we also have a full-time PRSS on staff, and she is equal and vital part of the treatment team as anyone else. What we see works for us is for them to each have a small caseload, to develop a unique service plan for each client and child. In our case, our family navigators are really prepared to sometimes have to create alternate treatment plans. For example, if custody changes, we may be working with mom still and the guardian of the child, and sometimes their interests may diverge, and we may have to do 2 different plans for that family. Provide assessments to identify needs and coordinate services, communicate with treatment team, refer to the services both within and outside of the coalition, and to connect people with PRSS. Although I think since we really first hired our first family navigators, our full-time PRSS, she is often in the hospital, boots on the ground. She often comes into contact with moms even before our family navigators do. Often even before I do as the therapist. Okay, this is just kind of a visual of our ideal is to be able to kind of assess, get that service plan in place, meet basic life needs, connect with a peer recovery coach and support groups for moms, connect family members. If they're going to be part of the support, we want to make sure that they are also supported. Any kind of additional supports for the family, whether that is like, for example, family members that are taking on an emergency kinship placement may qualify for TANF, and so our family navigators can help them with that process. We also have kind of later on in the process, as family is being stabilized, referrals to Kids Clinic, which is our interdisciplinary clinic led by a pediatric neurologist, and also includes speech language pathology, occupational therapy, psychology, River Valley RV Cares, which is our specialized child care center that uses evidence-based practices for children who have prenatal exposure to substances. So for example, they use low light, special handling techniques. It's really quiet. It's the most calming place ever, I can say. And we keep 2 full-time office space there so that we can have our family navigators kind of in and out, so they can continue to be convenient to the family, whether they're at the hospital or at that point in childcare, and also setting up the family to support them through that transition into the school system as kids, transition to 3, 4, 5 years old. Okay, this is just kind of a visual of our program regarding the MOM model, the maternal opioid misuse model. So on the left, you have kind of where referrals are coming from, our care team, which includes myself, our family navigator, our PRSS, but also the referring provider with releases in place is part of our care team. We make sure that we're in communication about relevant things. And then the output, you see referrals to all of the different programs that are partners within the Healthy Connections Coalition, but really anywhere that our clients can, if they have a need, we try to find a resource and fill it. And there are times you have to be really creative. So we actually had identified a list of situations that we kept running into where, for whatever reason, all of our patients were like exceptions to very specific exceptions to all of these community resources. And we applied for a safety net grant from the United Way. We're actually going to be kind of that will be officially conferred this afternoon. So we've found a way to be able to have a little bit of funding on hand for emergency situations when there are gaps in what exists already in our community. I have been talking for a while. Oh. Okay, and I would actually like to hear if anyone has questions, either about kind of how do you set up this kind of program, or any questions specific to patients or clients, depending on your context, how you may refer to them, any problems that you're running into where you are trying to get support for your patients or clients.
Hey, Dr. Price, this is David Baltiera. I'm at Harper's Ferry out on the other end of the state. So one of the areas that I think all of us struggle in our models is legal. And so, you know, that's always been a huge challenge. I think almost all of our patients, or many of them, struggle with legal issues, whether it's, you know, charges, whether it's harassment by the police, whether it's discrimination, you know, kind of, you know, now substance use is a disability, just came out in the springtime. And so all those kind of legal issues, I think it's really difficult to tackle those, you know, and so we've tried, but it, you know, unfortunately legal aid, it's stretched very thin. And I can't say that every lawyer is a great lawyer for our clients and patients. It's been a challenge. So I don't know if you have any thoughts on that, because we've almost looked at, you know, do we, you know, purchase somebody's time that can be an advocate for our patients, really.
Yeah, I think that is an extremely, that's a really important observation. I'll say a little bit about how that works for us. If we have folks that meet criteria for residential, we do have a relationship with legal aid where they'll get consultation if they're here, but that's not the majority of our patient population down here. And so really, I think building those relationships from the bottom up are important, but it is probably the hardest of any of these partnerships that we have made. I feel like home visitation was like an early adopter, healthcare early adopter, education, you know, maybe took a little bit more work, but legal has been really hard, even when we've gotten enthusiastic buy-in from specific pieces of the legal system. There's always like, yeah, but it's not going to work because of da 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 da. It's like some other piece of the legal system that I can't control, that you're going to have to talk to them. So persistence, I guess, has been really important. Something I've found frustrating over the years is that from the top down, a lot of policies have changed in ways that should be beneficial to our patient population, but it seems from kind of the bottom level, that boots on the ground level, people seem to either not be aware or they disagree and they decide their own opinion is best. And so it's really like trying to gain trust in these small ways that you can. We've had a lot of success specifically with the issue of trying to get women who are pregnant with SUD who are incarcerated into residential treatment. That's only one small piece of all the legal problems our clients have, but that's what we've had the most success with down here.
And then what about success with, because I know the Child Protective Services were supposed to be coordinating care plans, but our experience has been that reality is that doesn't happen until after the baby's done, and then it's not always, well, not always, it's usually not in a collaborative fashion. It's a separate path, whereas, you know, the law actually says it should be before birth, it should be collaborative, and I don't see that happening, at least in our area. I don't know if it's different where you are.
Yeah, I would say we do get, and I'll speak for for Cabell County specifically, I feel like attitudes have shifted quite a bit since I started working with this patient population in a favorable way. But I do agree that it can tend to be still very siloed and not as collaborative as places that we've had better progress. So, and yes, very, very often, it may be, baby may be 20 days old, getting ready to be discharged from the hospital before even mom hears from CPS. And often treatment providers are kind of left out of that, even when there is, a known resource person that the patient has identified. So usually patients are who pull us into that conversation, but incrementally by having, I think, good interactions and good outcomes on some cases, we've made some progress, but unfortunately it seems like it takes a long time. Any other questions, concerns, or looking for ideas for your own region or health system? I'll also add that another really, we've got a lot of really enthusiastic interest from drug court, but then it's just the idea of everyone being so busy to carve out time for collaboration and meetings. So I think one of my objectives is to make myself available to drug court, to kind of not just talk about what we do, but also to be made available to participate in MDTs, because I think that is one thing. The legal system is so used to mental health professionals trying to get out of collaborating, or the unpaid time it is required to collaborate on individual cases. Okay. Oh. So I do want to go ahead and talk about an example of sometimes we actually do, sometimes the thing that we think is going to help really does. So that's what we'll talk about a little bit here, because I know a lot of times it's really frustrating, but here's an example. So this young woman, we'll call her Helena Doe, just because Helena was the name that was already populated under this character when I created this slideshow. It's a 30-year-old woman with diagnoses of opioid use disorder, methamphetamine use disorder, and post-traumatic stress disorder. She entered our health system through the emergency room. This patient had significant spinal abscesses requiring surgery. When she was first admitted, she was very underweight, very malnourished, and she had been working as a sex worker was her primary source of income, and she was unhoused. She was stabilized on MAT at our general outpatient MAT program, and she continued to do well there as a really cooperative, pleasant patient, even though was not intending to really get into treatment, but her physical health kind of made that decision for her. But as she participated, she really became someone who gained a lot of insight and helped a lot of her peers. She got into a supportive romantic relationship, possibly the first one in her lifetime, and got pregnant. She had no other children. She actually didn't realize that she could get pregnant. We transferred her from our general program to the MARC program, which is our pregnancy program, integrated with OBGYN, and she began working with a family navigator. Upon delivery, her newborn had showed symptoms of NOWS, and she was stabilized at the NTU, and then per the patient's request was moved to Lily's Place and received a lot of additional support services once she was there. I would say, you know, this patient was highly motivated and had a lot of great internal resources. However, she had barely any support. So all of her family that we were aware of that were local to the area had active substance use disorder. And her partner was in recovery, but was the only sober person that she knew outside of treatment. But she did take advantage of every service that we threw at her. She enthusiastically participated. As a result, she successfully completed an in-home safety plan for CPS. And when I step back and think about the time frame, it just is, she's a miracle. Within a 1-year period, she went from homelessness and nearly dying to being a model patient. And she sustained that progress for quite a while. At last contact, she had reestablished her relationship with extended family who were not using substances and was on track to purchase her first home. This is a patient that if she had not been in a healthcare system that had support services available, I think would have been extremely high risk of attrition, of losing her from treatment. All right, and I'll quickly talk about a more recent case and how specifically in this case, the support services were able to really rally and set this family up for a good outcome. So this patient is a 35-year-old woman with a history of opioid use disorder and bipolar disorder. She had been admitted to the MARC program early in her 3rd pregnancy. Her eldest child was adopted by a family member. She also had a 4-year-old adopted into foster care. And it was actually after that process of losing her second child, she wanted to get sober. And she maintained her sobriety throughout her pregnancy and afterward until around 5 months postpartum. So I think she had about a year sober. However, she had done so well that she felt confident and visited with some family members, and this triggered a recurrence of use. Fortunately, this patient really was able and had the commitment to sobriety to let us know what happened. CPS told the patient that she had to get into a program, meaning a residential program. And this is someone who had a year of sobriety before this. I would call it even a slip up. This was less than a week that she had an unstable period for her recovery. But, CPS told her to either get into a program or her child would be placed in foster care. And this is a child that she's taking care of every day since birth. This is a patient who has done very well with recovery supports in place. She was extremely remorseful and motivated to comply with CPS. Because we had already been working with her and for so long, her PRSS was able to kind of leverage these qualities about the patient and vouch for her. And so drawing on relationships within the coalition, and I'll shout out to Lily's Place because I saw Rhonda on the call and they were a big part of keeping this family stable. Her PRSS was able to find her a bed, preventing this, in my opinion, unnecessary emergency removal. And mom and baby are currently doing well in residential treatment and has a lot of additional supports in place that really wouldn't be there without the professional support infrastructure that we have. Unfortunately, she just did not have the luck of the draw to be born into a family that was stable and absent of substance use disorder. All right, well, that's all I have for everyone. If you have questions later or things that you don't want to ask in the group setting, please feel free to reach out to me. My email address should be on the list, but it is mills126@marshall.edu.
Thanks, Jennifer. Appreciate all the information in the slides. All that'll be in the recap, of course. Are there any, we've got about 3 minutes left. So if there's any other questions, please feel free to put them in the chat or unmute and ask them. Do they have anything? If not, our next session is going to be on August 8th. So be on the lookout for the emails on that. And in the meantime, the evaluation link we'll put in the recap email as well. So please take some time to fill that out. Shouldn't take you that long. We appreciate everybody's responses on those. But we'll see you next time.